And welcome to the Dr. Bob Show. We'll be spending most of this show talking about a stroke, new advances in the treatment of stroke, new treatment that can allow people that may have been left with disability to recover completely. You and I are going to want to watch this show. My guest is Dr. Brian Wiseman. Dr. Wiseman is a board-certified neurologist, and he's the head of the Comprehensive Stroke Center at the University of Tennessee Medical Center. He'll be answering our questions, along with Dr. Patrick Brown, who is a radiologist and is doing interventional radiology to help people with strokes. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about a very painful type of arthritis and what can be done for it, and also sleep apnea. If you can't tolerate your sleep mask and you therefore are not treating yourself properly, there may be some new help for you. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Brian Wiseman, board-certified neurologist, chief of the Comprehensive Stroke Center at the University of Tennessee Medical Center, and he's going to be answering our questions. Brian, welcome to the Dr. Bob Show.
Thanks for having me.
So first of all, what is a stroke?
A stroke is when there is loss of blood flow or blood supply to part of the brain, and it creates symptoms and signs in the person having a stroke depending on what part of the brain is affected.
Are there different types of strokes?
There are different types of strokes. There's two main types. An ischemic stroke is basically when there's an artery that's blocked and that goes to part of the brain. So basically that part of the brain is deprived of oxygen and nutrients that's carried in the blood. The other type of stroke, which is less common, about 15% of strokes are what are called hemorrhagic strokes. Basically what happens is there's an artery that ruptures in or around the brain, and you lose blood flow to that part of the brain as well.
So when we have an ischemic stroke, there is a blood vessel that's blocked off with what, a clot or hardening of the arteries? What blocks it?
So that's a good question. So there are two predominant causes of blockage in the arteries. One is a clot that may come from the heart, for instance, and people that have atrial fibrillation, they can form little clots in their heart that can go up into the brain. And then the other blockage is from hardening of the arteries, or atherosclerosis, and that comes from years of high blood pressure, high cholesterol, diabetes, smoking, those types of things.
So everybody's afraid of getting a stroke because they're afraid of the problems after a stroke. Apparently it's very, very, very important to recognize signs of a stroke early. What are those signs and why is it so important?
So the signs of a stroke are varied depending on what part of the brain is affected. And I think a lot of people recognize, I have weakness on one side of my body, or I have numbness on one side of my body, and certainly those are symptoms of a stroke. Some of the other symptoms can be language or speech difficulty. They can't get their words out, or their words are mumbled or garbled. Sometimes slurriness of the speech. Sometimes people can have sudden dizziness and balance difficulty, maybe with nausea and vomiting. That can be signs of stroke affecting the back part of the brain. Sometimes it's vision loss. One eye can lose its vision, or maybe they have a visual field that's not normal.
Lost.
Yeah, that can be a sign of a stroke. Sometimes those are subtle signs of stroke and hard to recognize. The importance of recognizing and really getting to the emergency room very quickly is we have treatments that we can offer people that have strokes, but those treatments are very time dependent, meaning that if it's a day or two later, we may not be able to initiate any of those treatments.
What do we like the time to be? An hour, hour and a half, 2 hours? Quickly as possible.
As soon as possible, absolutely.
Is there a golden time?
The golden time really is as soon as we can start treatment after the onset of symptoms, the better chance that person has of a good functional recovery, which means they get back up and around and they go back to work.
Is there any reason if somebody's having symptoms of a stroke, if they suddenly lose their ability to use their right arm or their right leg, or they've got visual field problems or slurred speech, is it important for that person to get to the emergency room or to call 911 and get to the emergency room?
That's a good question, and I think oftentimes people like to try to get in the car and drive. It's very important to call 911. The EMS can get there, they can evaluate you or your loved one or your neighbor and start initiating treatments. And one of the key things that the EMS does for us is they tell us before they get to the hospital that they're coming with you. And that way, the stroke team at UT Medical Center, we're right there ready for you when you show up to the emergency room.
And those seconds of time are so, so important. So when the ambulance comes with a patient where there is a suspected stroke, you anticipate it's going to be a stroke, you have to be able to determine which kind it is, the hemorrhagic or the ischemic. So how do you do that?
Correct. Yeah, when we see people in the emergency room, we can identify just by looking at you which type. Is it ischemic, where you have a blocked artery, or is it hemorrhagic? So what we do is what's called a CT scan of the head, and that's an x-ray of the brain, and it tells us whether there's blood or not in the brain.
So you can tell right away if there's blood in there, that means a vessel has ruptured and we go one way, whereas if it's a clot, we start treating another way. So if it's a clot, if it's ischemic stroke, what treatment do you want to start quickly to help the patient not have residual problems?
So there's two main treatments that we have. One is called TPA, Tissue Plasminogen Activator. It basically helps dissolve clots. It's been around for stroke for over 20 years now. And that is a very time-dependent treatment. So the earlier we can get it started, the better. But its job is to get in there and dissolve those clots that are obstructing the artery. The second treatment we have is what Dr. Brown will be discussing later, is actually going in with a catheter and trying to get a clot out.
Are they able to do it that way? Can you go in and get the clot out?
You can, yeah, you can.
We'll be talking with Dr. Brown about that. I'm not going to let you steal all his thunder. Back to the TPA, how long does it take it to dissolve a clot?
Well, that depends. TPA seems to work pretty well for the small arteries that have clots in them. The larger arteries with the clots, it doesn't tend to work as well. And so sometimes we see improvement after TPA if its small artery is blocked. Sometimes when they're getting the medication, sometimes you don't see it until a day later, maybe a week later, maybe months later that you see that improvement.
When you have a clot in the brain, a clot in a blood vessel that's supplying blood to the brain, that's a shock, that's an injury to the brain. Does the brain come back quickly? I know it needs more oxygen than any other place in the body. Does it come back quickly, or just everybody's individualized?
Everybody's a little bit different. I've seen some folks that they are better the next day.
That must be nice when you see that.
It is nice when we see that, and the patients love it too, obviously. But the brain is very complex, so it depends on where the stroke is, it depends on how big it is, it depends on how healthy the other parts of the brain are. There's a process called plasticity of the brain, and plasticity essentially means that other areas of the brain that are not injured start trying to pick up the function of the injured part of the brain. So it kind of depends on where that stroke is to determine how much better someone's going to get and how quickly.
Is there any way to predict who's going to be the super responder or the one who may take a little bit longer?
There are some prediction scales that are out there before you give TPA. Is this person going to get, how much better are they going to get after we give them the medication? But in reality, I think it's very individualized, and it's hard to predict. When I'm giving someone that medication, are they going to be a lot better a day from now or 2 days from now, or is it going to take them a while? It's very hard to predict.
It must be nice to see people who have symptoms of a stroke and suddenly get better and improve, and then you can start working on what was the underlying cause to keep them better. Can you use a TPA and sometimes go in after that and you do the clot remover?
Absolutely, yeah.
And that's what we're going to be talking about when we come back. Absolutely. And I'm so excited to learn about how you can take a blood clot out of a blood vessel other than just dissolving it away with TPA. You'll want to stay tuned. We have been talking with Dr. Brian Wiseman, board-certified neurologist, and we've been talking about strokes, how we can identify whether it's a hemorrhagic, a stroke where a blood vessel broke, or whether it's a ischemic, and that's the kind that we're going to be talking about mainly in just a few minutes. Because the ischemic stroke is one where a blood vessel has blocked off its blood supply, and what can we do about that? We've talked about using TPA, a clot buster, a dissolver of clots, but now there's something brand new in addition that is going to be overwhelming in the effects that it has on some patients. My guest is Dr. Patrick Brown. Dr. Brown is a board-certified radiologist who does interventional neuroradiology. That means nervous system radiology. Patrick, welcome to the Dr. Bob Show.
It's great to be here.
So tell me, if somebody has a stroke, and it's an ischemic stroke, and they've identified everything, they've identified the patient, he's come there quickly, he's been within 6 or 10 hours, and they ask you to come in and look and see if maybe the clot can be removed. Tell me about what's going on.
Sure. So when the patient arrives to the emergency room, we get a scan to look at the blood vessels, the special type of scan where we give dye into the vein and we see where the artery is blocked or not. And once we've identified that it's a large vessel in the brain that's blocked, that sort of triggers our team to move forward and try to get the blockage out.
So if it is a large vessel, then that's the time where you come into the picture more so than if it's a small vessel.
Correct.
But is a large vessel likely to give more symptoms because it takes away more blood supply?
Absolutely. So we're talking about the main arteries that feed either the front of the brain or the back of the brain. And if one of those are blocked, then patients tend to be very symptomatic. And it's clinically identifiable, but imaging helps to clinch the diagnosis. And so once we've done that, then we bring our team in, and that's when we do a procedure or move forward with planning to do a procedure called a cerebral angiogram with thrombectomy.
Cerebral angiogram, so that's a brain blood vessel study in removing the thrombus or the clot that's there.
Correct. So what we do is frequently the patients are put to sleep with anesthesiology. It generally makes the patient more comfortable and able to stay still for us. In many cases when patients are having a stroke, particularly on the left side of the brain, they have a very hard time following commands. And so going to sleep helps us to keep the patient still, and it helps to make it a safer procedure. We use the arteries as a pathway to get to the brain by accessing the artery generally in the leg, sometimes in the arm. We can navigate a catheter, which is like a long, thin straw, and we can navigate that up to the blood vessels of the brain. And from there, we inject X-ray dye, take pictures with X-rays to confirm that the artery is either blocked or not. And once we've confirmed that the artery is blocked, using that method, we use that as a map to drive smaller catheters, some of them not much bigger than a few human hairs, into the blood vessel of the brain to then proceed with trying to extract the blood clot.
So what is the mechanics of being able to extract the thrombus, the clot that's causing all the trouble? Do you have little hooks on it, grab it? Is it a suction cup? Or what is that?
Very simple. So those, you've basically described two methods that are the dominant methods to take it out. So one method that is is called using a stent retriever, which is kind of like a hook. It's a stent is like a tube of wire, and in this case, many times people get stents placed in their heart or in their legs. In this case, we're using a small stent which is attached to a wire, and we deploy that stent inside where the clot is located, and we leave it there for a little bit of time, and then we pull that stent down through the catheter that's in the neck, while usually sucking aspiration on the catheter in the neck, and that can pull the clot out.
You can get some suction that helps pull the
Correct.
clot out of that. Can you tell when it's coming out? Do you get a feel for that?
Yes. So it's really interesting. So one of the other ways that's sort of developed over time is putting a balloon inside the artery in the neck, and using that as a way to, once you cross the clot, once you've put a stent inside that clot, it can break up and move downstream. So if you have an inflated balloon below that, it can help prevent that clot from breaking up and moving downstream. So we have an inflated balloon, and we have a stent there, and we pull everything down while pulling some suction on the main catheter, the main tube. And when the clot gets inside that main tube, you can't pull suction anymore. So it's clogged. So you pull everything out, and then when you clear the catheter, frequently you find a clot either in the stent or in the aspirate.
What does a clot look like?
It depends on it. We're learning more about that.
Sure.
So it depends on the pathology that caused the stroke. Generally, by what I mean by that, it frequently depends on how old the clot is. So if a patient, for example, has had a clot in their heart, for instance, atrial fibrillation, if they've had that in their heart for a long time, and then that little piece of clot flies up into the brain, that clot could be very hard and almost kind of like scar tissue, almost like very fibrinous. And in clots that are younger, less mature, less organized, they tend to be sort of a gelatinous type of what you typically think of a blood clot would look like.
Which is the easiest to pull out?
It generally, the younger clots generally tend to come out more easily than the older clots.
What are some of the stories? You and I were talking earlier on what we said was the Lazarus effect. I
Right.
mean, there are people that really, when you start the procedure, they don't have much function,
Right.
and then what happens?
So sometimes you will see patients who are very, very disabled from their stroke and not doing well at all. If you get the clot out quickly, then they tend to, some of them, once you wake them up from anesthesia, gain function back very fast. And they, for example, will start to try to talk. If they have one side that's weak, that side they start utilizing very, very often on the table. And
to me, that's the most exciting thing that I can possibly imagine. Somebody that's got an incapacitating stroke begins to be able to feel and walk and talk. It must be very, very exciting to be a part of that.
It is. It's very gratifying. We have patients who come back later and their livelihood was going to be completely devastated by this event that they had no idea was coming. Not only is it the patient who is debilitated, but the patient's family will often be very negatively affected from a severe stroke, and that makes a big impact on the patient's family as well.
So how frequently are you doing mechanical thrombectomy?
We are doing them more and more. As you and Dr. Wiseman discussed, our indications for mechanical thrombectomy have expanded, and we're doing them more and more and more. We did 2 of them today. And
you had mentioned you'd done 45 or 46 since the last 3 months.
Since January, since the beginning of the year, we've done over 40.
Wow, and that means, do you think it's becoming more prevalent? Are we identifying quicker? Are we doing a better job to try and get that patient well
Well,
quickly?
I think that it's a combination of the second two. I think that stroke, we probably are seeing about the same number of strokes are occurring. It's just that we are, the population, other physicians, emergency room doctors, EMTs are becoming more and more educated and understanding what we're capable of doing, and they're getting to us more quickly. In addition to that, our indications have expanded, so we have a wider window in which to function.
Instead of 6 hours after symptoms, you can go maybe
24 or more sometimes.
24, sometimes a little bit more. And you can still get excellent effects some of the time.
We get great results. The earlier, the better, obviously.
Sure.
So just because we have a 24-hour window, so to speak, in which to work, that's never a good reason for a patient to delay.
Absolutely.
And that's a really important take-home message is that if you're having symptoms that, or your family member or a friend or coworker are having symptoms and you think there's a stroke, to call 911. The faster you can get to us, the more opportunity we have to help you. So,
Patrick Brown, you're an excellent, excellent, excellent teacher. Thank you for coming to the Dr. Bob Show.
It's great to have you.
Thank you for telling this. To me, this is new and exciting and saving lives and helping people, which is what we went into medicine for.
Absolutely.
So thank you for coming to the Dr. Bob Show.
It's great to be here.
Great information. Early recognition of signs of stroke may save somebody's life or make them more functional also. So be sure that you're having that in your brain to be thinking if somebody has symptoms of a stroke. Now you're going to want to stay tuned. We're going to be talking about painful gouty arthritis and sleep apnea. Are you having difficulty with your mask? Just don't want to wear it if you have obstructive sleep apnea? We've got some information for you. You'll want to stay tuned. I want to thank Dr. Brian Wiseman and Dr. Patrick Brown. Wonderful discussions on newer treatment for strokes that can save people's functions. Now, for questions from you, the viewer, that I think will be important to your health. Dr. Bob, how is gouty arthritis, different from other forms of arthritis? It's a good question. There are several different kinds of arthritis. We think of the wear and tear, osteoarthritis. We think of rheumatoid arthritis. Gouty arthritis is deposition of uric acid crystals into the joints. And when uric acid crystals get inside of a joint, it causes a tremendous inflammatory reaction with red, hot joints. You don't want to touch those joints. The most common joint is the big toe. And the big toe, you don't want covers on, you don't want anything because the pain is really, really very, very significant. We can usually lower the uric acid after we treat appropriately to get the inflammation away. And then we have to try and prevent more and more gouty attacks in the future. So if you've got gout or you've got arthritis in that big toe, see your doctor. Let them get you on a program to keep you from having so many attacks. Next question, Dr. Bob. I cannot tolerate my CPAP mask. Well, people that have obstructive sleep apnea, they actually stop breathing several times an hour. And when they stop breathing for 10 or 15 seconds, they don't get enough oxygen to the brain. They wake up with headaches. They're sleepy during the day. They fall asleep when they shouldn't. They don't perform well. They can have irregular heart problems during the middle of the night. And so the doctor makes the diagnosis and they put a little mask on the face to help push air past the back of the nasopharynx, the back of the nose. And when they do that, sometimes people can't wear their mask. So they've got little nasal pillows now that they can put right on the nose. You have to attach it with a rubber band type to keep it secure. But that helps a lot of people. And then there are different types of what I call valves, where we can put a little device over the nose and it will let air come in. But when you try and blow air out, it has to go open up the airway that's having obstructive sleep apnea. So know that there's some different things that they can do. There's even a nerve stimulation to keep the tongue out of the way. And so there's several things. If you have obstructive sleep apnea, it is harming your health, and you need to be sure that you can use a proper mask to get you where you don't have that apnea anymore. So talk with your doctor. Tell them you're having trouble. Tell them you need something new, and be sure you get a mask that you can wear that takes away the problem of stopping breathing during the middle of the night. It's all the time that we have for this show. Remember, the 4 things that we like. Number 1 would be exercise. Exercise reduces stress, makes us feel better, gives us collateral circulation in the heart, lowers our blood pressure, helps us lose weight, does everything that we should be doing. Be sure that you exercise on a regular basis. Get those tennis shoes out. Get 7.5 hours sleep. If you're not sleeping well, talk to your doctor about why. It could be medications, it could be pain, it could be that you don't know how to go to sleep, or it could be that when you wake up, you can't go back to sleep. Talk those over with your doctor, he'll help you. And eat properly. We all know that we don't eat properly. Look what you're going to eat small amounts. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. Laugh a lot, have a good time, enjoy laughing, and you'll stay